Excellent. Good morning, everyone, and welcome to this meeting of the Board of Directors of Lincolnshire Partnership NHS Foundation Trust. My name's Kevin Lockyer and I'm the Trust Chair. It is our usual practice to start our board meetings with either a patient or a staff member story. We do that because it helps us to ground some of the conversations that we're going to be having later on during the course of this morning and this afternoon, and it helps us to keep focused on patient care and staffing related issues, and hopefully helps to keep us sensible. We've got a staff story this morning, and we're really lucky to have Ken Bonzongwana here to tell us his story. Now, Ken, I've heard some of your story. I've had that privilege before, and I know it's genuinely inspiring. So I'm really looking forward to hearing more from you this morning, and I'm really grateful to you for finding the time to come and talk to the board this morning. So over to you. The floor is yours.
Thank you. Good morning, everyone. I'm extremely nervous this morning. However,
Ken, I should have said, please don't be nervous. Just relax. Everything's going to be fine. Take it at your pace. The floor's yours. We'll be gentle and receptive. Please don't worry. There's nothing to be nervous about.
Thank you. My name is Kenneth Bonzongwana. I trained nurse back in South Africa, and having qualified 22 years ago, I came over here in UK back in January 2003 and work in independent private hospitals, rising up to the ranks to be a ward manager that I am today. I was very fortunate enough to be supported by incredible professionals in my career as a nurse from day one since I arrived in UK. I had an opportunity to work in various places around the country, moving from Sussex to Manchester to London, and until I decided to relocate to Midlands December last year. The transition has been wonderful, but it had its own ups and downs, and that was to be expected. Firstly, how did I get to choose Lincolnshire with Court? This was about a word of mouth through a former colleague who alerted me that she is working around Lincoln and it will be good if I could move up for the quality of life. And therefore, I didn't know the place. I didn't know that there's a place called Witham Court, even Lincolnshire here in Midlands. But I was drawn from moving away from London and its expensive life to give my family a quality of life, for my children to be able to learn that there's another way of life other than the rush of life in London. So talking about recruitment, it's critically important that I first want to thank Debbie Blunt, Jane Andrews, and Don Baker for giving me a chance to be part of the trust and the older adults community. Debbie Blunt, moreover, who was with me all the way from interviews, agreeing for me to come and see Witham Court under safe conditions during COVID-19 pandemic way back in December, January time, taking me around Langworth Ward, where I felt welcomed by staff that I was seeing them for the very first time. This, to me, was no doubt a contributing factor in deciding to accept the role. The feeling of being accepted and wanted even before I could start my role was very key as I interacted with the staff that Saturday morning. What was positive from my commencement of my role was to have a buddy system to take me through, and my managers here, they have approached Sue Brace, who is a ward manager for Brant Ward, who was quite phenomenal in making sure that I have a better overview and a better understanding of the role, the issues at hand, as she was actually managing Langworth and Brand at the time. I'm extremely grateful to Sue because she introduced me to so many colleagues and professionals, planned this and executed it very well. I'm mostly grateful of the fact that it has actually given me composure to be able to have a very solid start where I feel supported from day one. And this is something that I will always advocate for at any level of recruitment of staff, because it's crucial that those first days, they may determine whether you can cope with the support from the staff, or you might also be feeling like you are left on your own to figure out what you can do, and thereby breeding a sense of negativity. So for that, it's something which I, as a manager for Langworth Ward, I will always make sure that whoever is coming in as a new person who's recruited in this ward, I will probably do exactly what was done to me, making sure that I have a buddy system for anybody else who comes in, just to walk the person through. Relocating from London to Midlands was not particularly easy, as I had to look for places to live, furniture and spoon and everything else. But the relocation package gave us a relief. It meant that we had to use the money that we didn't have at the time. Perhaps one was thinking that maybe buying items to assist with the move or dealing with issues of removal could be much better if you probably have an advance to begin with, because it's a start that is hard, compounded by challenges of living in a new environment. However, with the support of everybody else, my colleagues, my land managers, they've made it quite possible. The response of the HR team to support me with the relocation package, and to make sure that I have an understanding of how the policy is in terms of NHS. Again, the challenges of coming from private sector to NHS, I would actually say that I've worked mostly in private sector and with NHS as a locum nurse. I am now getting acquainted with the processes and get to understand how these impacts or improve our day-to-day delivery of care. In private sector, it means that there is a quicker access to the top executive in terms of decision making. For instance, in relation to areas like procurement, it could be quicker and streamlined. I wouldn't critique of any process now, but I'm just willing to learn and observe how things are done before I can have an opinion of what is working well and what could be done differently, but achieve desired outcomes still. Again, touching a bit about the role, the challenges of the new role as a Band 7 in Langworth, as someone who has not worked for this trust and as someone who has not worked for NHS that long. I will say that Langworth Ward, as part of all the adults and frailty division, is a wonderful place indeed, with wonderful team of professionals, right from the ward RC to various disciplines, and the support that I receive has been overwhelming for me. Yes, the challenges of the new role are huge, because I'm aware that I'm new in the division, and therefore there is a pressure to learn very quickly. But with the support from Amanda, Don, Jackie, and all those who are supportive of me, including the staff that I work with, Band 6, Band 5, and all the support workers, all the clinicians, I do believe that I'm in a safe space. I am willing to learn from everyone and contribute to making Langworth Ward the best in delivery of care, staff professionalism, positive attitude at work, increase in staff morale and support, reducing sickness rate, staff development and staff retention are some of the things that I'm already working on and which I'm quite passionate of. The dementia pathway services within LPFT's older people and frailty division primary aim is to address and support personalized needs by putting the people who use our services at the very center of decision making and working with them and their communities to shape and deliver the care and treatment that achieve the best possible outcomes. And this can be achieved when all the trust values are espoused in anything that we do, particularly as a manager, having integrity, leading by example, particularly valuing everybody else, using an inclusive approach, which already it pays dividends, because vulnerability as a manager where you can learn even from the support workers is key. I will then summarize by taking a quote from a leader, Nelson Mandela, who said, "A leader is like a shepherd. He stays behind the flock, letting the most nimble go out ahead, whereupon the others follow, not realizing that all along they are being directed from behind." I thank you.
Ken, thank you very much indeed. That was really good, and you had no reason to feel nervous at the beginning of that. And thank you for sharing your personal story with us. Dawn, is there anything you want to add to what Ken said?
No, we're very fortunate, because as soon as we started interviewing Ken, within 5 minutes we knew we had the right candidate for the post, even though he didn't have experience of the NHS, even though he didn't have experience of older adults. We knew very, very quickly that from the things he was saying in the interview, the warmth, the way he talked about patients being at the heart of everything, and his support of the staff team just fitted in with the philosophy of the trust and the division. But we're also recognising as a division the need to make sure that Ken was supported from day one, hence the buddy system, hence Deb sort of supporting that pre-journey into our service. Before we'd even started, there was lots of contact and support, and then making sure that Sue was that buddy, and that, but also our expectations, because we know that Langworth had some needs around retention, staffing, managing patients, and being patient and not expecting Ken to be able to succeed on day one, and giving him that time to do that as well. So we're very, very fortunate.
Thank you, Dawn. I completely agree with that. I've got colleagues who want to comment or ask questions, but I'm going to take Chair's prerogative and go first. When I spoke to you on the ward a few weeks ago, Ken, the thing that struck me, and why I said that your story was inspirational, is the modesty with which you convey the way in which you've dealt with what is, by any measure, a massive transition, both, kind of geographically, culturally, and then a shift from the private sector to the NHS, and a move out of London into relative rurality in Lincolnshire. Any one of those on its own would have been a massive test for anybody, and the fact that you've been able to manage all of those is testament to your personal resilience, and I am I think what word am I looking for? I'm quite in awe of the fact that you've managed to navigate your way through all of that. But I've got a couple of questions, if I may, in the context of that. And the first is there and I ask these questions because I know that we're going to be recruiting other staff from overseas, and it's a personal priority of mine to make sure that we get that process right, and we welcome and support people when they come to work for us as effectively as we can. So my question is there anything that we could have done better as an employer to help you manage those transitions? And is there anything that we did really well that you'd want us to make sure that we didn't lose sight of and continue to do in the future? So I'm getting two questions in for the price of one.
Okay. First thing first, thank you very much, Kevin. It's I must say that first thing, the one thing that I will talk about is the enormous support which I've received. It's one thing which made me feel comfortable. When you feel wanted, when you feel that people want you, it makes you to do more, to appreciate more, have gratitude of the opportunity that I've been given. in all circumstances. The process of recruitment, I must say that Debbie Blunt has been very instrumental, because she had a blow-by-blow emails checking me up. She even gave me time to think of whether I would accept the position, even though I've put myself for an interview, and in that way agreeing that I should come and see Langworth and be familiar with the place, and all this not to put pressure on me at the time. And I think that was key, and most of all, it actually gave me an opportunity to meet my colleagues, which at the time I have not even accepted the post. But the acceptance which I received that Saturday morning, it was overwhelming. It was like the staff have already know something about me. And these are the things that made an impact for my family as well, to be rein in the decision, even though we were all in it. So I think that's very, very crucial, because even though you take a bold step to apply for a position to work, you are actually worried as to how you're going to perform, how you are going to be accepted, how are you going to be supported. And so that was key. Something which was done very well, and I think I've mentioned it briefly. It's very, very important that we make people feel comfortable. It's very, very important to understand that you might not know everything, but if you need to know something, who are your support systems? And in the 360 figure here, I know exactly who to go to if I need some help. And it's that reassurance that I think the trust is doing remarkable well in that. I don't know whether it's across the trust or it's actually here, but right from Steve to Dawn to Amanda, Debbie, Jackie, everybody else who is my land manager and those that I work with, they are particularly supportive to my plight. And in that way, it makes me to want to do more. So I will touch on those things, but I know that you spoke about retention just briefly before I dwell a lot. I do realize that as I've already started to recruit the staff for my ward, that some of the posts are not able to attract any candidates. And I wonder whether there is something that I need to do where I could be able to go even to universities, for instance, and raise a profile of older adults, pitch it quite high at the university so that the students have an understanding that this is a service which could be enriching. This is a life skill that some of us, or those who have grandpas and grandmother, they could be able to use that transferable skill at home. So it's one of the things that I've already talked about with my colleagues, that what can we do to be able to pitch the older adult services high in the agenda of the universities in nursing studies, and in that way we might yield results. Thank you.
Thanks, Ken. That's really helpful. And before I pass over to colleagues, one thing I would say is don't trust anybody that claims to know everything, because they almost certainly don't. So in order, Sharon, I think you were first.
Thank you, Chair. Hello, Ken. I'm Sharon Robson. I'm a non-exec. Hi, and I chair the Quality Committee. I think, you know, your leadership qualities and your you know, the way you talked about the vision of the organisation and the values and inclusion has been great today. And clearly, you know, you're an asset to us. Just in terms of that bit that you said around universities, I agree. I think that's a really good way forward. Schools of nursing, etc. And many years ago, when I was a deputy director of nursing, that's exactly the strategy we had in place when we had trouble recruiting. What I wanted to talk to you about was retention.
Yes.
So you are going to be highly sought after by other organisations, no doubt.
Yes.
At different levels as you rise up in your career. And in terms of retention, I want to know what we can do to keep you.
If you just give me the support, I'm quite content to learn from everybody else. One of the things which I've done is to put myself in this situation where I don't have experience of working with older adults, but I trusted my capabilities. And secondly, I trusted that those who are here will be able to enable me to reach the heights that I could achieve. Of course, I'm still a young man. I have ambitions to climb up, but for now, I think it's very important to sit down and learn and understand the ethos and the objectives and everything else about the trust. It's important that I have a clear understanding of the dementia pathway within the division. And any opportunity that comes, it might be more of maybe, and I think I must be grateful, I'm already attending a leadership development course, which I believe our Director of Nursing, Anita, has funded that with the support from Don and everybody else. Those are the things that will be able to make me to relax and, you know, learn more and be able to say, what next? What other assignment that I could be assigned to? What I have learned in the years is to try and see if there is anybody else within the work that I do that I can always follow and mentor and watch. And in that way, I'm able then to follow up and take some of the roles which are higher than what I'm supposed to do now. And in that way, it doesn't really phase up to say, you need to humble yourself, you need to learn. And anybody else who would want to aspire to do well would want to learn more. So I'm not in a hurry to go where else. I just need to learn and be able to understand the ins and outs of my role within the trust. And if there's any opportunity down the line, again, I will see if it fits to what would be my ambition continuing forward in my career.
Yeah, thank you, because I think our retention strategy moving forward is critical as an organisation, that training, development, supervision, all those aspects. Thank you.
Thanks, Sharon.
Thanks, Sharon. And I think, you know, if I may, there's a general point there, isn't there, which is that we're more likely to retain people if there's a clear career and development pathway, because that's what you've just described, Ken, isn't it? A desire to continue to learn and to develop. And if we can offer you that opportunity, you're more likely to stay with us than go and find it somewhere else. And that's a, you know, that's a simplistic way of putting it, but that's how it feels to me. Ananta.
Thanks, Kevin. Hi, Ken. I'm Ananta Dave. I'm medical director here at LPFT. And the calm and dignified and courageous way in which you told your story, I think, belies the extraordinary adaptation and resilience you had to show over the years in order to reach where you are and for people to recognize your potential. So I thank you for giving us a story of hope and for being a role model, because, you know, as we've been discussing as a trust, as we proceed further with international recruitment, both amongst nursing staff, and we are doing it now for medical staff as well on a bigger level. I think the points you have raised are very, very important. I think for me, a couple of comments. For the trust, what I take away is we should not underestimate the level of support the pastoral care, the induction, everything that is required for a new person to settle into a new culture. I mean, very experienced clinically, but settling into a new culture. So I think a takeaway point is those who are doing this commendable work in the trust, and really, hats off to Debbie and team and Dawn here. I think that should be adequately reflected in, the job plan or whatever it is, their day-to-day job, because that is equally important work. Supporting new colleagues and helping them settle is very much a part of our quality and retention strategy. So I think the trust to give attention to how we resource that kind of support required.
Yes.
And the other takeaway point for me, I suppose, Ken, and correct me if I'm wrong, is the ongoing induction. I mean, there is obviously an induction when you start, but it shouldn't stop after a particular time and say, that's it. I think it has to be ongoing so that, there's that constant checking in and you're getting to know various elements. So that's the other point I take away. The third thing I wanted to say is really to invite you to become a member of our various staff networks. You may already be a member of them, and that's fine. But I think as we try and make sure that we're doing the right thing for people entering our trust, whether it is from elsewhere in this country or from abroad, there is a lot to learn from how it has been, how you have found the experience. So do consider becoming a member of our staff networks. We are happy to share details. There is a Black, Asian, minority ethnic network, men's network, women's. I mean, you can be an ally and become part of any network, however you identify. So I think you would be a role model, and there is a lot we can learn from you. So thank you.
Thank you very much. Thank you.
Thanks, Ananta. Completely echo all of that. And I think that it's possible, isn't it, to undercook the sort of support that we're providing to people in Ken's position, but I don't think it's possible to overcook it, as it were. Yeah,
absolutely. Just one point, and Ken, I came to this country 26 years ago, so 26 years ago to the date, actually, and I completely echo the things that you said about the support that's required. So thank you for that, and it takes me back. Thank you.
Yes, thank you.
Thanks, Ananta. Sarah.
Thank you. And Anta pretty much covered everything I was going to say. Sorry. Hi, I'm Sarah Connery, Ken. I'm the Chief Executive here at the Trust. So and she said it a lot more eloquently than what I could say. So all I want to say is thank you so much for taking the leap to join Team LPFT, and thank you to Dawn and the rest of the Older Adult Division for, making you feel supported in it. Something that we've got in our system, people strategies, that sense of belonging, and it's in the National People Plan, and I'm really pleased to hear that what we're trying to achieve is actually having positive impacts in terms of that sense of belonging. So I know our head of comms would love for you to be used as a case study, and I know you said you were nervous, but you speak really eloquently and passionately. So if we could twist your arm on that one, that would be great, because I think it would be a really positive thing to do. So thank you, and thank you for your time today.
Thank you. Thank you. Appreciate
that. Thanks, Sarah. Di.
Thanks, Kevin. Hello, Ken. My name's Di Bailey. I'm one of the non-exec directors, and I've put a comment in the chat because I would really like to talk to you in a bit more detail about a number of things outside of this forum. But thank you so much for what colleagues have already said in terms of an inspiring talk this morning. I think your willingness to embrace the NHS and different cultures and different ways of doing things, I find quite humbling. So my question is really, I think we, you bring that different cultural perspective from South Africa, and I wonder what we can learn from you in terms of the cultural experience that you bring to the Trust, because I think we shouldn't always assume that we've got it right in the UK or in Lincolnshire. So I'd be interested to hear your thoughts about what maybe we can learn from South Africa in terms of mental health that that would take us forward, perhaps in some different ways.
Thank you very much, Di. It could be a broad question that needs a broader analysis without delving into politics of it. But in a nutshell, I think the story of our upbringing in South Africa during the apartheid years has brought resilience to to be where we are, some of us today. We were constantly pushed to extremes of emotions almost every day to strive to live and be better. And so never in my life when I was a young boy having dreamt that I will be in England, because when I look at the map of the world geographically, it was too far from the tip of Africa where I was. But here I am with all the breakthroughs that happen in life. Here I am sitting here as a manager in Langworth or the Witham Court. What I can say is that if you believe in anything, with all the support, you can achieve it. If you believe that there are people around you who will be able not to be cheerleaders, but they will be able to have a tough love to tell you if you are not right, so that you can be able to reflect and learn. Those are the things that shape my being. Those are the things that have made me to be who I am today. But I was, and I think I must have shared this with Kevin when he was here. I was raised up by my mom and my dad, who have never been educated, but they valued education so much. We could not afford luxury, but all they gave us is love in abundance. And it is that sense of wanting to do better for somebody else, that sense of wanting to help others, that I think even here in LPFT, if all of the staff members would have a sense of wanting to do better for somebody else, it leaves a very good feeling within you as a human being that you have helped someone, even in a small scale of the things. So the situation that I can say is it's a story of rise of the phoenix. It's a story of trying to push against all odds. It's a story of recognizing that there is a term which again our leader Nelson Mandela coined called Ubuntu. You are what you are because I am. And those values, I have espoused them at a very age that I would not be in existence without the people who are surrounding me. So this is already what I'm trying to say to the staff here, that when you come to work, you're coming to work because your colleague is coming to work, and we have something to give to the patients that we have. And so in every aspect, I mean, we can broaden this in any way, but in a nutshell, I always try to do what I think is right with the support of everybody else. And every time when I go home after the day, I reflect about the decisions which I've made. How can I make it better? How can I have a better response to yield a better results? So that has been the critical aspects of it.
Thank you. I think that's really powerful. Those are really powerful messages. Thank you.
Thanks, Di.
Thank you very much, Di. Two more contributions. Tim, a question from you.
Hi, Ken. Tim Harry.
Hi, Tim. Hi, Tim.
Hi. Thank you so much for that. Really enjoyed the story. So a number of things resonate for me, but like you, I'm a newbie on the block, as you might say. So I'm still learning about the trust. The other element really is around the move from private to public sector, which is another thing that I've sort of gone through, but quite a while ago, I guess, really.
Yes.
And it's probably a comment more than a question, because I think you know, there are differences. And one of the things when I first moved to the public sector was some people would sort of question, why do you want to move to the public sector from the private sector? Isn't the private sector wonderful? And part of my response was, well, no, they're different, and they may do things in a different sort of way. But I think my comment is around I'm sure the trust can learn from your private sector experience on matters. I think you're taking the right approach, because I think you said, you know, it's too early to critique some of these sort of things. But my observation would be, I think the trust is really good at looking at continuous improvement. So I think, you know, when you're ready and you've got some ideas and so on, I'm sure there will be a good reception to that. Thank you.
Thank you very much, Tim. Yes, indeed. I think, as I said, I think now I'm in a process of just absorbing and retaining and learning to see how things are done. But there are already subtle differences which I can already see, and those are to be expected, because I think there are differences there. But in whatever way, I know that it will be mischievous of me to think that all is wrong. No, that's not the sense. But one of the things which I really wanted to say is, even this opportunity to present my story in the board this morning, it's quite extraordinary for me, because in private there is always a quicker way to get to the top executive. As I say, with the clinical governance of the private sector, it seems that even the staff on the floor have easier access to the board. And so here I am now. So there's no difference whatsoever, because within where I am, there are structures that are able to lift up some information and raise it to that level. So what you call board to ward and ward to board, and to close that loop. So those are the critical aspects which I think I will be looking at, and I'm familiar with them, and I will really appreciate that. And everything else which has been suggested, I take on board. So thank you very much, Tim.
No, thank you, Ken.
Thanks, Tim. We've got time for one more quick comment. I think Anita.
Thank you. And actually, it's hi, Ken. Sorry, I'm Anita Lewin. I'm the Director of Nursing, AHPs and Quality. And it's just it's more a comment really, but based on the work that Sharon spoke about retention, and you made reference to the ward managers training programme, and I think that's something for us in LPFT that we really need to get the balance of. I think we offer a really good suite of internal training. But actually, I think it's important. The ward manager training programme that Ken spoke about, that kind of we've arranged, is a national programme. It's really well recognised. I have to be honest, it probably isn't the cheapest training course that's on the market.
It's not.
But the what you hear about it and the feedback from it is incredibly positive, and I think it gives people the opportunity to kind of meet people from other organisations and build those relationships. So I think for us in LPFT, it's important that we get that balance around what we offer internal, but the opportunity for people to kind of spend a lot of time external to the organisation and bring that back in. Yes. Was one of the key points, and I think that's really important. And the other bit is back to the case study. I think I agree with that, Joe, and I think it's really important that we get that from Ken to use in LPFT, but probably worth using it back in South Africa too, because if we're going to get more of you, Ken, it would be an absolute privilege. Yeah, an absolute privilege. So I think that potentially is something we need to look at. But thank you for sharing your story today. It's been a joy to listen to.
Thank you very much. Thank you.
Thanks, Anita. And a quick final word from me, Ken, to say thank you. And I would like, if you can find the time at some point, to continue the conversation about leadership. I'm really interested in your observations, you know, drawing on Nelson Mandela's thoughts around leadership. And it just strikes me that, you know, we can learn not just from you know, what you bring in kind of technical skill from South Africa, but what you bring, you know, culturally around different models of leadership, from which, you know, which just enriches our learning and our understanding. So that's a conversation that I hope we'll be able to continue at some point.
Thank you.
Offline and maybe not quite so much in the public gaze.
Thank you.
Thanks for your time this morning, Ken.
Thank you very much. I appreciate all, and I'm so grateful. I'm so grateful. Thank you.
It's our privilege. Cheers.
Thank you.
Right then, let's move on and move to the formal agenda. I don't know whether we have any apologies for absence.
Everyone is here.
Good, thank you. Any declarations of interest that are different or additional to those reported in writing? No.
Yes.
Andy.
Yes. Could I just come in?
Philip, rather. Sorry.
Yeah. Sorry, I couldn't get me hand up function to work for some reason. But
right.
anyway, yes. On agenda item 2.2, Young Minds Matter. I guess I need to declare an interest because of my connection with North East Lincolnshire Council, and I suspect I probably need to leave the meeting for that item as well.
I think that's probably the right thing to do. Philip, thank you. Thanks for that. Let's move on then. Minutes of the Board of Directors meeting on the 30th of September. Does anybody have any comments or points of accuracy? Karen.
Yeah, hi Kevin. I just want to extend my apologies to Sarah. Her title in the minutes is incorrect, and I will make sure that that's addressed in the final version that's uploaded on the website.
Thank you. I didn't notice that. Thanks for that. Any otherwise people happy for me to sign those as an accurate record? No one's saying no, so I assume yes. Thank you very much. Let's move on then to the schedule of actions. Any questions or comments on the schedule of actions? I can't see any. We've got a couple of items that we'll pick up as part of substantive discussion on the agenda. So I will move on. A couple of introductory remarks from me then before we get on to the Chief Executive's report. I'll keep this brief, as is my wont. My first point is, and this will have escaped no one's attention, and I mention it because it's an important bit of context. The Lincolnshire system remains exceptionally busy. We are not insulated from that in any way, and the last few weeks have been, if we needed them, a really stark reminder that COVID-19 hasn't gone away, and we continue to feel the pressure, both in terms of outbreaks in our services and the impact on staff, but more widely the impact on the NHS system in the county as a whole. I won't be the first person or the last to predict that it's going to be a busy and difficult winter, and I think it's just worth prefacing everything else we talk about today with those remarks. More widely, the process of recruiting to the Integrated Care System Chief Executive role continues, and we've got, as does the recruitment of a chair for the ICS, which was unsuccessful the first time round, and we continue to watch those developments closely. And I know, as Sarah will touch on in her Chief Executive's report, we continue to be really strongly engaged with those developments. And that's about it, really. I mean, it's a difficult operating context, and it's a difficult and uncertain time still around the ICS and other strategic developments, and all of that, my observation would be, is stretching our exec colleagues. There is, to be slightly flippant about it, a lot of it about at the moment, and I think in all of our discussions and conversations during the course of today, we just need to be conscious of that. So happy to take any questions or comments on those opening remarks, but otherwise I will hand over, Sarah, to you for your Chief Executive's report.
Thank you, Kevin. Morning, everybody. I'm Sarah Connery. I'm the Chief Executive here at Lincolnshire Partnership and Foundation Trust. As Kevin has said, that we're operating with some very in a situation of increasing demand and still having capacity impacts as a result of COVID. We have had a number of outbreaks on some of our units and latterly in one of our community teams. We are seeing increasing infection rates and also in terms of COVID positives at Lincoln County Hospital as well. So I think it's fair to say in the general population we're seeing some COVID fatigue, for want of a better turn of phrase, and we continue as an executive team to make sure that we continue to push on continued effective use of personal protective equipment and also lateral flow testing and making sure that staff continue to upload those results. At the same time, we're in booster vaccination season, so we're really encouraging people to have their flu vaccination as well as COVID-19 boosters at the appropriate time. So we're doing lots of comms and trying to offer staff the capacity to make sure that they can have these to make sure that we're keeping our colleagues and our service users as safe as we possibly can. In terms of the national position, there has been some winter pressures funding made available specifically for improving discharge and flow through mental health services over the winter period, which, as Kevin, you've said, is going to be extremely pressured. We've been working across the system with our voluntary sector colleagues, also with our commissioning colleagues and the local authority and ULHT to make sure that we've got a really robust plan to use that money as effectively as possible over the winter months. So we are looking at a mental health assessment centre which will really support with the ambulance service and the police in terms of handovers, expanding our crisis cafes across the whole county to reduce some health inequalities on the East Coast, and also looking at bolstering our mental health liaison services in the hospital for all ages and particularly for children and young people as well. So it is a significant amount of money to spend in a short time, so we're cracking on with spending it to make sure that we're making the most of it. We're also really encouraging our staff to make sure that they complete their Nhs Staff Survey. So we're tracking it quite closely on a weekly basis in terms of the uptake for the staff survey, which is closing this month. So just want to thank all staff who've taken the time to complete it and encourage anybody else who hasn't already to please do so. It won't have skipped anybody's attention that we've got the Globe's Eye on Glasgow at the minute with COP26 taking place, and similarly in the NHS we're really pushing forward now on our net zero agenda. So we will have our 3-year green plan coming to the board in January, and then we need a system plan signing off in March. So really pushing forward in terms of better use across the system in terms of inhaler gases, desflurane, decarbonisation of our fuel supply. But now we're really starting to ramp up in terms of engaging our staff as well, in terms of what we can all do as global citizens to reduce climate change. In terms of the local systems, so we've got Humber Coast and Vale Integrated Care System, which we're still playing strongly into. I won't dwell on that one too much on this paper because we've got a separate paper that Jane is kind of covering under 2.2 after this paper. But in terms of the East Midlands Alliance, thank you to all of our board who were able to join the development sessions to talk about the progress that's being made with our provider collaboratives in those specialised services. And we have a revised collaborative agreement that we're going to pick up on in private board later on today. In terms of Lincolnshire, we are now, as we've reported before, in a recovery support programme as a system, given that we are rated as a system oversight framework level 4. Just to say that LPFT as a trust still remains at level 1, but as a system we are rated at level 4. which we're working really hard together as a system to get ourselves out of. So we've got 3 key areas of focus for this year: care close to home, musculoskeletal and prescribing. And we've had system sessions, checks and challenges in October. Again, thank you to colleagues if you were able to join in terms of a position statement with where we are, but there'll be more of that coming through to each of the boards in future. The Mental Health Learning Disabilities and Autism Partnership Group continues to meet and connect around some key areas. So the group met for the first time since July last month. We had a presentation on the Community Transformation Programme and deliverables for 21-22, an out of area update. So we've had great success in terms of acute and psychiatric intensive care. We've now got a lens on rehabilitation placements who are out of area. We also talked about learning from the Corston Park safeguarding report and had a real focus on joint accommodation strategy, where we're working as a system to make sure that our learning disability service users have got the supported housing that they need. We're also doing some work to build our prevention concordat for better mental health. So as a system, we want to put in our pledge nationally that we're a system that wants to get serious about prevention in the mental health arena. So we're building up our priority action plan for that as well. Autism strategy. So as part of the refresh of the 3-year autism strategy, we want to make sure that we're addressing the increasing weights that we've touched on in previous boards as well. And there'll be a refresh of the autism strategy that's coming through before the end of this financial year. I just want to say a big thank you to Ananta Dave, our medical director, for the work that was done around our dual diagnosis conference. This is a really well attended system conference to talk about how we're using our learning going forward and what investments we might need in the future to make sure that we've got effective pathways going forward for dual diagnosis, where substance misuse, drug and alcohol substance misuse features as part of someone's comorbidities. Finally, I just want to end with a big thank you to our quality and diversity team for their work around Black History Month. We had a number of virtual events that took place, really inspirational sort of play about Rosa Parks, where we were asked to claim our seat on the bus to talk about the power of standing up against racism and racial inequality. So it was really inspirational. A massive thank you to everyone who's involved. As part of Black History Month, LPFT became the 6th NHS trust to pledge support for the See Me First badge. We've got mine on here. So this is about making sure that we are promoting equality, diversity and inclusion for staff, all staff, service users, carers, volunteers and stakeholders across Lincolnshire. If people are interested in getting a badge, please do get in touch and I'll make sure that happens for you. So finally, just want to end with it is a very challenging position out there for our services. So again, I do say this every month, but I can't say it often enough in terms of a massive thank you for delivering our safe and effective services for our service users. You know, in a couple of weeks' time, we have got the Hsj Awards. The trust has been shortlisted for Mental Health Trust of the Year, but whether we win or we don't win, it's just a massive thank you to everyone for what you do each and every day for our service users. It is going to be a tricky winter, but I'm very encouraged that this has been acknowledged by the centre and we've got some additional investment to make sure that we're able to see our service users safely and appropriately. So that was everything for me. Thank you, Kevin. I'm happy to take any comments or questions.
Thank you very much, Sarah. Tim has both a question and a comment.
Which usually means I'm not sure whether it's a question or a comment. Sarah, thanks very much indeed. And I think the report reflected Kevin's earlier comment. You know, there's an awful lot going on out there at the moment. I really just wanted to pick up on one line which is in there, and the sort of support and workload on the executive team at the moment? And in the autism one, you were talking about program management resource. And I would imagine that actually getting program management resource, not just in that area, but across a number of areas, is a really important part of how you can achieve what you need to achieve. So I guess my question really is around what is the thinking on the program management strategy for the trust, as maybe I'm not quite clear what the current arrangements are, but you know, is this an area that needs bolstering?
Yeah, really good challenge, and it's something that we've talked about just recently, last night actually, at our weekly chief executives meeting, because we do have program management across the system. There are some high numbers in terms of people who've got program manager or transformation manager in their job title. So we have been talking about how we might pull some of that and have something akin to a transformation hub, where we've got some very intelligent, very skilled, very experienced program managers, and how do we use that resource more effectively? So that's one element of it. What there is, though, I think, is a bit of a gap in terms of the capacity. So that's the next step in terms of what we're actually trying to achieve over the next 3 years, particularly in mental health, learning disabilities and autism arena. And how do we make sure we've got the right, not just program management, if I'm honest, I think it's the financial analysis support and also business intelligence support. I think that's a theme that comes up in a number of papers later on as well, around the need to have effective business intelligence support. And again, I think this is something that we can work on as a system. And I don't just mean in NHS trusts, I mean in the local authority as well, particularly around autism, for example, because it's about what's happening in schools, it's about what's happening in wider healthcare settings, in care settings, in the general population, and within community assets. So it's about bringing that resource together to make sure we're not duplicating as much as anything. But I believe in the autism strategy, once we've got the roadmap set out, then we'll need to make sure that we've got investment going into that particular area to make sure we're achieving our strategic priorities. So there's a number of threads there. I've waffled on a little bit, but no, it's a concern of everybody's in a financially challenged system. How do we get the capacity to actually transform?
Yeah. I'm happy to have a chat if it would help sometime, because I think Public Health England was in a similar position around PPM resource and how to best use it in the organisation. And I was head of profession for that, so I had a particular sort of interest, but thank you for that.
I will pick up that. Thank you, Tim.
And I think my observation, Sarah, this reflects the conversation we've had before, is that there is just a pure capacity issue here, and one of the ways that we free up exec capacity to focus on things that execs need to focus on is to take some of the what is effectively program management burden off of them, because I think you're doing things at the moment that other people could do if we had the other people to do them.
Yeah, there's only so many hours in the day.
Well, indeed there are. Chris.
Yeah, thanks, Chair. Chris Higgins, Director of Operations. Just to say that from a division operational perspective, that capacity conundrum is something that we're continuously monitoring and reviewing, and we've just put in some extra, over the kind of last 12 months, extra what we're calling service development leads, which were relatively senior posts, to be able to lead programmes of work around the various work streams. And so that should add some operational capacity. But I think what Sarah's hit on there particularly is it's that BI capacity that we're often finding that we're drawing on more and more as there's more programmes of work coming on, and also that project management capacity, that kind of diligent process management, again, a capacity that's needed around that as we've got more work streams coming online. So yeah, it is something just to say that we're continuously keeping an eye on in terms of that operational capacity, but we could always do with more.
Yeah, thanks, Chris. That's helpful. And a question from Andy.
Thank you, Chair. Andy Spring, Non-Exec Director. Hi, Sarah. You dropped a very nice little one-liner in there that there's quite a bit of winter money around. So I just wondered if you could expand a little bit on how we're going about using that, and in particular what we're using it for? You mentioned absolutely. Kind of discharges, but just a little bit of an expansion if possible.
Yeah, so there's obviously quite a detailed spreadsheet behind it, and we are building on some of the successful programs from last year. We've talked about it at this meeting before, for example, the carers support through the inpatient wards to sort of facilitate smooth discharges and better experience in the inpatient settings. But the key area is to have a mental health assessment area that will actually take patient walk-ins. So as I've said, in terms of colleagues across police and East Midlands ambulance services, and also reducing, we're forecasting up to sort of 70% in terms of the footfall through A&E for people. Obviously, if people have a physical need and they've self-harmed and they need to patch up, they need to go through A&E. But where not, we can divert those people, which obviously eases pressure in the A&E department, but also then gives people a better experience as well while they're suffering with their mental illness. What we can't do, because we know we'll come on to it again in future papers, is recruit lots of qualified staff, because we're already struggling in terms of the recruitment pipelines anyway. So there is a big focus on peer support workers, volunteers, making sure that we're using the voluntary sector. So we've actually ran through this plan with, the Shine network, for example, in terms of bolstering up and rolling out more of the managed care network programs. And in terms of the crisis cafes, it's just about making sure they're aligned with our services in terms of the pathway. It's not necessarily us delivering it. We'll just have oversight. And a big area as well is comms for the mental health helplines, and there's a text service as well. And making sure our primary care colleagues know about those and are actively promoting those other alternatives just to sort of referrals into the service. So it's quite a long list, and if they are successful, there is discussion about them rolling into the future years as well. So there's a lot to do in a short space of time.
Thanks, thanks for expanding that. Thank you.
Thank you.
Thanks, Andy. One last comment from me, Sarah, and I know that you get this, so forgive me if it's an egg-sucking point, but given how much there is going on, you need to make sure that you use non-exec colleagues and the board to help kind of prioritise our way through that through all of that complexity, because I think that's one of the board's key roles in all of this is to help with that prioritisation and make sure that we've got the resources to back the priorities that as we recognise them.
That's helpful, thank you.
Okay, let's move on then, and I think at this point, Philip, I need to ask you to excuse yourself while we move on to item 2.2. And Jane, I think you're speaking to this.
Thank you, Chair. Good morning, everyone. Jane Marshall, Director of Strategy at Lincolnshire Partnership. This paper confirms a decision taken by the board around one of our outstanding CQC rated services in North East Lincolnshire in the Grimsby area. We're proud to have been able to deliver this service since 2012. And this service serves children and young people's mental health needs in a highly effective way. It's currently rated outstanding by the Care Quality Commission. But changes in the policy context have made it necessary, really, for the board to look at whether we continue in the longer term to keep this service within our portfolio. And the difficult decision has been taken not to re-tender for this service if commissioners re-tender it after March 2023, when the existing contract runs out. LPFT is absolutely committed to ensuring a highly effective quality service remains into the future and including up to the end of March 2023. And we have a resourced transition plan in place to make sure that there is an effective handover of this service to whichever provider takes it on after March 2023. The only final thing for me to say, Chair, is that this service is in a really good place. So we have a transition plan, but we'll be handing over a really effective service to whichever service provider comes next. And I'm happy to take any questions from board members. Thank you.
Thanks, Jane. I mean, the paper rightly acknowledges the risks around service transition, and I know that we're fully seized of those. So the board's asked to receive the report. Are there any questions or comments? No, thank you very much, Jane.
Thank you.
Let's move on then to item 3.1, which is the risk register.
Thank you. Should just wait. Do we know, is Philip back with us?
Yes, he is, Anita, so press on.
Brilliant. Thank you. Thank you. So I'm Anita Lewin. I'm the Director of Nursing here at LPFT. So this paper is the public risk register. I'm hoping board members will see we've done a little bit of tweaking since the last one. I know this is work in progress and has been work in progress really for the last couple of years, but we have done some work on it this month just to really focus us on the parts of the document that we really need to concentrate on. So it kind of explains how the scoring is reached and really gives more detailed updates since the previous risk register. So I'm happy to take comments about the layout at the end of this, but in terms of the content held on the organisational risk register, we currently have 14. 29 risks are also monitored on the divisional risk register. We have made a decision as an executive team that we will be looking at the divisional risk registers on a regular basis too, as opposed to the ones that just come to board, just so board are assured that we're also looking at the divisional risk registers. In terms of updates, since last time I presented this, we've had 2 additional risks added. They're in a different format, as you'll see. They're there in your papers, but they're in a different format because there's more fields to fill in when risks are newly added. We haven't closed any down since the last board meeting, but we have made a couple of alterations. We've moved one to the private risk register and the risk 169, which relates to the work on Charlesworth Ward. The risk level has reduced and therefore that has transferred to the divisional risk register for monitoring. I don't intend to go through the details of the risks other than that, because our executive colleagues, if they wish to kind of come in, I'm sure we're happy to talk to theirs. In terms of the inpatient nurse vacancy, that is actually Jane's risk. I'm hoping the next paper that I present around the safe staffing picks up a lot of the work that Jane has led on that agenda. So some of the comments potentially around that one may get picked up in the next discussions. But other than that, I'm happy to take any comments and questions.
Thank you, Anita. I have a comment from Chris first.
Yeah, thank you. Yeah, Chris Higgins, Director of Operations. It was just to identify the 2 new risks there, 182 and 183, that both relate to the Community Mental Health Transformation Programme, and really they're just reflecting the complexity of that piece of work, that we're working with multiple providers across the community and voluntary services sector, and a number of those providers don't have systems like Rio, and that we use as our clinical system, and obviously primary care are using separate systems. So the complexity of transitioning and sharing data across multiple providers as part of a single team approach is complex, and obviously then brings some inherent risks with that. And similarly, being able to report on that, which is 183, be able to report on that in a consistent way with what's expected nationally around performance and activity against community transformation, again, is posing a challenge and a risk. But we have brought in some additional capacity and some specialist expertise to help with that, and we're linking in with the national team to move things along. So it feels like we've got the right checks and balances in place, but it was important that we highlight those particular areas. So yeah, thank you. Thanks, Chris. A question from Di.
Thanks, Anita. Di Bailey, non-exec director. Can I just ask Anita, when I was looking at this, and I appreciate we don't want to get into the detail, but for some of the risks, I could see the that the difference between the current risk and the target was was a way to go. So in some we were going from extreme to low, for example, and what I was struggling to reconcile there was then what the gaps were and and what was in place to mitigate against that. So it left me with some questions about how we're making judgments about those time frames between the current risks and the target risks. And I just wonder if you could provide some assurance around that, really, please.
And I agree, and I think some of the detail is the work that we'd spoken about previously around the training that's required for this, because it's often very subjective, whoever is kind of completing it at the time, and where that fits, because we have such a wide range of staff that are fitting in and completing these risk registers. Part of the work that I've asked to be picked up in line with this is part one, which is the presentation we've seen before us today, but we spoke on our board development day about the need to have some additional training and resource for our staff around completing the risk assessment. It's one of those things that we kind of assume people know, but actually I think it's in order to bring not uniformity, because that's not, I'm trying to, can't find the right word, but in order to bring something to it that where we understand where people are coming from with that scoring, that it just doesn't depend on who is filling it in on the time. I think that's the next piece of work that we need to undertake.
Thank you.
Thanks, Di. And with that in mind, Anita, I think it is the risk register is always going to be a work in progress. I think that the additional detail that we've got around the kind of granularity of the risks and the actions that we're taking are really welcome. We could polish some of it a bit further, but that's always going to be the case, I think. So thank you. It's a much more solid thing than we had only a few months ago. So I'm really grateful.
Thank you.
I'm going to do some juggling around with the agenda, Anita, because I know that you need to be away by 10:30 and you've got 2 items to deal with between now and then. So I'm going to take both of those next.
Okay,
so I'm going to go on to 4.2, which is the safer staffing review.
Right, thank you. So yes, I've got the safe staffing review. For colleagues that are present on this board meeting today, I mean, Kerry Woodcock did, who's kind of my head of nursing and professional lead, and to be fair, safe staffing guru, did provide a training session for us, which I really hope colleagues found helpful. And I think what is on the front page of this paper, which kind of relates to the triangle, really does kind of clearly lay out that the safe staffing review and the work that we undertake to kind of produce the paper that is in front of you today, which is something we do twice a year, is really kind of based on kind of the evidence-based tool, which is the Nhs, which is what we use as an organisation, the outcomes and the professional kind of judgment. So we try to keep this paper small because the detail behind the Nhs is really quite, well, it is quite detailed, to be fair, but I think the work that Kerry does with the operational
we appear to have lost Anita, or at least I have. I don't know whether
I have too.
Yeah.
Yes.
Okay.
Yes, likewise.
Okay.
I'll call her. And if we want to skip on to another paper while I ring her.
Thanks. Let's do that. Can we take 4.1 then, Sharon, which is the report from the Quality Committee meeting on the 14th of October?
Yes, thank you, Chair. So as you say, this is from the Quality Committee on the 14th of October. Just to note that the minutes of that meeting aren't yet available because of the timescale between the committee and the board. The committee focused on reviewing the quality aspects of the board assurance framework, which are rated as partial assurance. I won't go through the whole paper, but I'll just highlight a couple of areas. So we had a deep dive into the NICE guidance, the National Institute of Clinical Excellence guidance, and the dedicated work that was being undertaken to establish robust governance around that guidance, and gained positive assurance from that report. But to note that it does still require embedding in the organisation. So we now have a robust framework. We now need to, as a committee, monitor that it's well embedded in the organisation, and we'll continue to do that. We also received a report on the establishment of the trust-wide quality improvement framework and the action plan over the next 12 months to embed that piece of work. And again, received positive assurance from that, but noting that there is a requirement to keep a close eye on that and the capacity required to take this work forward. The committee approved the terms of reference of its subcommittees, subject to additions to the Infection Control Subcommittee. We had previously made a decision to receive a dashboard for safeguarding to provide a better level of assurance for the committee, and it is the dashboard that's received by our commissioners, the CCG. We received that, and it did provide significant assurance for the committee. And just to note that post-committee, myself, Anita, as the Director of Nursing and Allied Health Profession, and the Trust Board Secretary, met to review the areas of partial assurance on the BAF that were not considered during that committee. And as a result of that piece of work, we've identified the need for a deep dive into carers, which will take place in the future and is referenced on the board assurance framework later in the agenda. And that's because there were three risks that were identified that related to carers, and they were identifying carers, involving carers in incident reviews, and developing feedback mechanisms in relation to carers. So they're the main areas I wanted to raise today. Thank you.
Thanks, Sharon. If people have got any questions or comments for Sharon, can they let me know in chat? I'll park those for a minute, Sharon, and come back to you, and then let Anita finish her 2 items. I'm sorry, that's slightly clunky way of doing it, but I'm conscious of the fact that Anita needs to be out the door in 13 minutes time. Anita,
honestly,
back to you.
I can go to 1:45. I'm fine.
But I'd rather you didn't.
Okay, so. Thank you. So back to the paper. As I said, the first part kind of demonstrates the process that we go through to undertake the safe staffing review. I've also taken liberty with this paper through talking with colleagues to go through some of the detailed work that the Rapid Recruitment Group has undertaken. So we've used this paper to go through the safe staffing processes, but also to give board an update on the fantastic rapid recruitment work that Jane and the team have led. I won't go through the detail of all the new posts and what has happened, but I think there's a detailed list there of the work that we've undertaken to really get on top of some of the nursing vacancies in the organisation. In terms of the process, I keep getting lots of flashing up now telling me that I've got an IT issue, so if I could go off again, please forgive me. The paper goes on to go through each of the wards and the process that's been undertaken around establishments and around skill mix. There was a time when the MHOS tool really just used to focus on qualified nurses, but fortunately somebody has seen the light, and I can say no more than that, and that now includes allied health professionals and other professionals and their contribution to staffing establishments. So, but in terms of outcomes from the safe staffing reviews, both the older adult division and the adult inpatient division aren't recommending any changes to their staffing establishments. we will see that there is one request for change from Ash. Somehow along the line there was an anomaly recruitment of staff against their established fully to meet the staffing establishment requirements of that ward. To be fair to the ward, they have continued to kind of meet their staffing establishments and using bank and agency. I do think in terms of bank and agency, there's one thing I just want to draw to kind of colleagues' attention. We work incredibly hard not to use agency staff because we know potentially there could be quality issues around care and continuity of care for our patients. But when we do, we try very hard to get block books and actually take people on lengthy kind of 2 or 3 months at a time contracts, and I think that really helps around the quality of patient care. I've been out and met quite a couple of the agency staff, and they actually feel part of the nursing of the teams. So I think that's quite important because we often hear kind of a lot about agency staff and quality of patient care, but we work hard to overcome that. So in terms of this paper, what I would like to say is in terms of the establishments of the ward, we're not recommending any changes at this moment in time. We are recommending that we look at the establishments and kind of ensure that they're not focused on nursing, because I think it's important to consider the rest of the workforce in that, and that's the next piece of work. As I said at the beginning, I hope that the training that kind of board colleagues received from Kerry kind of has helped with some of the understanding around this paper, and I'm happy to take comments and questions. Thank you.
Thank you, Anita. And if I could impose on colleagues, please, a requirement to be brief and to the point with those questions and comments. Tim, you first, please.
Yeah, thanks, Anita. And just to fully support the training that Kerry gave, I thought was excellent and certainly gave me assurance around the process and thinking behind the staffing levels. My comment, and I'll just leave it at that because I think it's a discussion for another day, was around the language issue around safe versus optimal, which is something that the most system approaches. But I think that's a one for another day.
Yeah, absolutely. Yeah, no, and I think that's fair. Yeah, we did have that discussion. Yeah.
Thanks, Tim. Di.
Absolutely echo the comment about the usefulness of the training. I need to just conscious that some of the new ways of working that we're implementing, particularly around older people and in some of our community services versus inpatient. And I just wonder if you could say anything more about how we're modelling that patient flow in terms of thinking about staffing going forward, so that effectively we've got people in least restrictive conditions for the least amount of time, really.
I'm not sure if I can do that one quickly, but I'll certainly try. And I think in terms of, I think the pathways that Chris spoke about earlier, actually, when he was talking about kind of the capacity in the teams, I mean, all of our pathways now are about patients in the least restrictive environment for as short as time possible. And I think the new services that we've heard about previously as a board around the community-based services, certainly the moves that we've put in place initially as a response to COVID, but that we've approved as a board to continue with, kind of demonstrate our need to kind of have people in kind of the restrictive environments of inpatient facilities for as short as time as possible. In terms of the safe staffing review, at this moment in time, it relates just to inpatient wards, but I know Kerry is linking closely with colleagues with community services, because in terms of establishments for those teams, I think it's that there are some really key points that we can learn from what we do for the inpatient staffing and take it through to kind of some of the principles for community teams too.
Okay, thank you.
Thanks, Sharon. Di, rather. I'm trying to read who's next and to talk about people at the same time, so forgive me. Jane.
Thank you, Chair. Jane Marshall, Director of Strategy and People. Thanks for the report, Anita. I just wanted to make a comment about international recruitment. and link it to the story we heard from Kenneth earlier on. We've put, to give the board assurance, we've put pastoral care arrangements around those 10 international recruits who will be coming to join us from the end of November. But I think following the story this morning, the importance of getting that absolutely right has been made vitally clear, hasn't it? So I'll be bringing something back with Anita's help on just what that looks like, so that the board can get that assurance that once we have those people joining us, we'll do our level best to welcome them properly and make sure that they are able to join the trust in the right way. Thank you, Chair.
Thank you, Jane. I think they're really important points, and you know, we will undoubtedly come back to it. Okay, thank you. And I think the last comment is, let me see, Sharon.
Yes, thank you, Chair, and thank Kerry for a very clear report, Anita. I just wanted to check on page 3 and 4 where it talks about recruitment to posts, that they are actually, I don't want us to get as a board into the false assurance that we're recruiting lots of people. Are they recruitments from internal posts, or are they from external posts? So, you know, a true increase in staffing level.
I honestly think there's a mixture of both, Sharon, and I haven't got the detail in terms of how many were internal and how many were external, but I can get that going forward. But I think there's a combination of both.
Yeah, that's
what I would say is we did as an executive team have a follow-up meeting to some concerns that we had raised about inpatient staffing nursing numbers, particularly last week, and we took the entire cohort from Lincoln University that have newly qualified, and there is definite shift for the better in our vacancy rates with qualified nurses, that we are seeing a much better position than we have. So I can assure the board, I don't know in terms of this one the exact numbers of which are internal moves, but in terms of our qualified nurse vacancies, we are in a better position.
That's great. Thanks, Anita.
Thank you, Anita. I don't want to prolong the discussion for obvious reasons, but I just want to say, yeah, it's a really useful report. I haven't had the benefit of the briefing on an host yet. I look forward to that, but it's got the right amount of detail and provides us with the right degree of assurance. So I'm grateful. Anita, I am now very conscious of time. I'm quite happy to deal with item 4.4 in your absence, Anita. Sarah's quite happy to take that item. If you would like me to release you now, as it were, rather than
probably, because I really don't want to rush this. It's not fair to do that. We need to do justice to this one, so I'll probably log out.
Yes, no, that's very sensible. That's what I'd prefer you to do. So thanks, Anita. So I just want to go back, then skip back, if people can keep up with me, to 4.1 and just check whether or not there are any questions or comments on Sharon's paper on the last meeting, the Quality Committee. I didn't pick any up at the time. If not, then I propose that at this point we take a brief break for 10 minutes or so that people can go make a cup of tea or whatever, and we'll come back for item 4.3. By my clock, it's now 10:28, so we'll come back at 20 to 11. Thanks, everyone.
Hi, Kevin. Just to let you know, I'm here because I think the next paper is mine.
That's right, Ananta, it is. Thank you. Okay, it's 10:40, so let's restart. The next item on the agenda is 4.3, the Learning from Deaths report. Ananta.
Thank you, Kevin. Hello, all morning once again. Ananta Dave here, Medical Director at LPFT. And the report summarizes the work that's gone on in the Mortality Surveillance Committee, looking at the numbers of deaths, the structured judgment reviews, and the learning points arising as well as good practice. So the paper, I hope, is taken as read, and happy to answer any questions. Just to bring your attention to the fact that we are seeing increasing detail coming up regarding the dual diagnosis, or those patients who, in this case, who've lost their lives, who had both a mental illness and a substance or alcohol misuse. And as our focus continues on that area of practice, we are identifying more learning points and reviewing more cases where that particular combination has been the case. Also to note the altered arrangements around the learning disabilities review, the leader reviews, where patients with a learning disability have died, and the arrangements for that have now moved to the NHS Midland Centre as detailed in the paper, and we continue to be a part of that and take part in the reviews as we are allocated. And these are patients who are not known to LPFT, but we take part in the overall review process. And apart from that, the work is ongoing, and happy to take any questions. Thank you.
Thank you, Ananta. I don't see at the moment any questions or comments. I have a question, Ananta, if I may, and that is to your point about the increased numbers of individuals with dual diagnosis, and take your point about learning from that. I wonder what the process is for crystallising that learning into service changes or system changes. So I wonder if you could just expand on that a little bit.
Definitely, thank you. I mean, that has been an increasing focus actually, and particular attention over the last year. So what we have done as a way of learning, not only from structured judgment reviews, but also based on patient and carer feedback, audits, and as part of our system-wide good practice groups that we've set up and looking at data is, for example, we've reviewed the dual diagnosis care policy, clinical policy, as you will see referenced in the report. There was some lack of clarity, and that was referring to the old policy. It was due for a review anyway, and as part of our process of improving our practice around patients for dual diagnosis, we have reviewed our clinical policy, which has now been accepted and ratified within the trust. Also, so that clarifies people's responsibilities around what is necessary to be done. We have taken a no wrong door approach, whereby if patients do have a combined problem of mental health and dual diagnosis, it's about signposting in a supported way to the right organization and being part of that conversation around transition or handover or joint care planning, rather than refusing those patients a service. We are continuing to, for example, improve our data collection. We are working hard with the business intelligence team to make sure that we are capturing the data. Right at the moment, we don't have a full picture of every patient who might be presenting with a possible dual diagnosis problem, because the data might be collected in different ways. So we are continually improving on that. We are working very hard with the commissioners. I mean, a large part of it is about the commissioning up of a joined up service. I mean, we provide the mental health part of it, and We Are With You provide the substance misuse part of it. But as we approach the next phase of commissioning for these services, the plan is to work very hard with the commissioners. And the conference that we held at the beginning of October, which was contributed to by everybody within the system, and where we learn from external good practice, helps us do just that, look at various commissioning models, looking at having the right resource and expertise within teams, whether in the mental health services at LPFT or within primary care and We Are With You. So these are some of the pieces of work that are going on as a way of learning from these steps.
Thank you, Ananta. That's really helpful. And it's almost a trite point, isn't it? But it's the handovers between services and between organisations that are one of the material things that increase risk. And not for today, but for the future. And I know that that Sarah's focused on this, that we need to think about LPFT's role in the system to think about how we mitigate the risk of, manage those kinds of handovers. But that's a strategic issue, and we'll have plenty of time to talk about that in the future. Di, I think you've got a question for Ananta.
Before that, can I just make one more point, if I may?
Of course.
Some of the initiatives that have been introduced have improved those experiences. For example, we have workers now working with the liaison team, with the inpatient teams, where they take part in care planning meetings and in joint assessments. So that has made a big difference. And one of the presentations at the conference was the very good feedback it received in terms of reducing those kind of risks that you mentioned, Kevin. So just want to, mention that as well. Thank you.
I'm grateful, Ananta. Di.
Thanks, Kevin, and thanks, Ananta, for the report. Really helpful. Can I just check in terms of the suspected suicides, and I appreciate that we've not had these confirmed yet. Just looking at those figures, to me that seemed quite high. Are we seeing a rise, or are these within
They are within expected limits. What's happened is, I mean, if you look at the national data that's been released, Lincolnshire is in keeping with the trends with the national data. Yeah. So since around 2019 or so, there has been a slight rise in the country's suicide rates, and that is reflected. So it equates to around 0.5 deaths more per month in Lincolnshire for suicides, but that is in keeping with that. There is no data to suggest that we are outside of national trends, which does not mean that there is complacency. The aim is to continuously keep reducing the numbers of suicides, but I also suspect that, given the whole issue around COVID and the impacts of it, which are generally felt over the coming years rather than in the year of the pandemic, I suspect that we might be seeing, as we are going to see an increase and have already seen an increase in the demand for mental health services and various mental illnesses, we are likely to see a similar rise, but we have to keep a watch on it. And the National Confidential Inquiry and the ONS Office for National Statistics is keeping a very close eye on suicide numbers as we emerge out of this phase of the pandemic. Thank you.
Thank you.
Thanks, Di. Sarah.
Thank you. Yeah, I think with Anita now left, I feel like I need to say what Anita would say, which is around reasonable adjustments training. And I know she wants the ICS system quality group to sort of do a bit of a cross-system piece of continuous quality improvement work around, for example, the Oliver McGowan training and reasonable adjustments. I think we need to really get serious about that now, and it really ties in closely to learning disabilities review, and indeed autism, because that's the next step, isn't it, in terms of those reviews as well. Thank you.
Thanks, Sarah. Thank you very much, Ananta. A really helpful paper, and with some really clear and good insight. Thank you very much. Let's move on then to item 4.4, which in Anita's absence, I think, Sarah, you're stepping into the breach.
Yes, thank you. It's my job today to take the board through this final report following a combined domestic homicide and serious case review, which was actually published on the 29th of October this year. So this is in the public domain and needs to be received and considered by the board. So this is an extremely tragic case about a gentleman called Peter and his family that took place in 2015. It's fair to say this was an individual with very complex needs. He was diagnosed with a rare genetic disorder in early childhood. This meant that he had profound physical and intellectual disabilities that impacted on his life, effectively requiring 24-hour care, which for the most part was provided by his parents. Unfortunately, Peter and his mother died in a fire at the home. Peter was actually rescued from the fire but suffered severe burn injuries and smoke inhalation and sadly died in hospital 2 weeks later. Ron, his father, did make his way out of the home and made a full recovery. Judith, Peter's mother, could not be recovered and actually died in the house. So fire and police investigations concluded that the fire had been started by Judith, but her intentions in doing this are unknown. So there has been a full independent domestic homicide and serious case review, and the report is appended to this cover report. I think it's fair to say that there are some certain themes that you can pull out of the report. So this is around domestic abuse between Judith and John against each other, as well as concerns highlighted about their poor mental health, which were said to have been exacerbated, as you would expect, by full-time caring responsibilities. There's also themes of safeguarding concerns being reported, but I think we've seen in a number of safeguarding reports thresholds not being met, but also concerns being seen in isolation rather than, for want of a better phrase, dots being joined up across the system. And that feeds through in the recommendations. So there are 14 recommendations in total, nothing specifically for LPFT, but regardless of that, we want to make sure that we have learned. This is 2015 and the system has moved on, but I believe that there are elements that we need to make sure that we are that's really sustained. That's the other issue as well, where we've got safeguarding reports like this, that we ensure that any learning, whether thematic or specific, when we embed recommendations, that they are actually sustained. So on page 2 there, you can see some of the main issues for LPFT. Lack of professional curiosity following several unusual interactions with the family by crisis and learning disability services. Suggestions that domestic abuse could have been contributing to Peter's increasing challenging behaviour, and that wasn't followed up. And also, really importantly and specific, I think, for LPFT, the third bullet point there, talking about occasions when there should have been more explicit discussion about Peter's mental capacity. There is a theme through the report of reluctance of Judith and Ron to actually accept professional help, and they were actually declining services on his behalf. So it's felt in there that due consideration wasn't given to the Mental Capacity Act in relation to Peter. In terms of developments since 2015, there has since been a Lincolnshire Domestic Abuse Partnership, which has been set up with a specific intention of preventing such tragic consequences of this into the future, and LPFT does play very strongly into that. Also, we have the Mental Health, Learning Disabilities and Autism Partnership Group, which is very much multi-agency and a really important point of connection. Anita, our Director of Nursing AHPs and Quality, is a member of the Safeguarding Adults Board, where these recommendations will be tracked from a governance point of view as well to ensure that sustainability. So just to conclude, this is a really tragic incident, and this is for the Board of Directors to acknowledge the consequences of the incident, to receive and note the findings of the report, and note the developments since the time of the incident back in 2015. So I will do my best to answer any comments and questions that people might have.
Thank you, Sarah. Sharon.
Thank you, Sarah. It's not so much a question as a reflection, but as you rightly said, this mother and carer, she clearly had several cries for help. She was asking about being sectioned, attempting overdoses, so attempts at potential suicide, and refusing cancer treatment, lots of cries for help. She saw several health related people, including the HIPS team in the hospital and some of our own services, but also the GP. And as you rightly said, the escalation and the escalating risks weren't addressed. It was all dealt with as individual episodes. And in my mind, you know, health have a lot to contribute to this review and the learning for this review. And I think part of that is around the universal offer. So although she was deemed not to have a specific mental health problem or needs, clearly there's some underlying mental health issues related to her circumstances. And going forward, as a quality committee chair, I'd really like to explore in the action planning around the recommendations how the universal offer for mental health and as working as a healthcare system could in future, you know, ensure that the multi-agency approach happens earlier on, and we don't see things as isolated services.
I couldn't disagree more, Sharon. And I think in terms of as well our carers support offer as well, in terms of helping people deal with what would effectively be, you can see from the report, you know, real isolation for this family. So yeah, thank you for that. Thank you for your comments.
Thank you, Sharon. Andy.
Thanks, Chair. Andy Spring, non-exec. Thanks for presenting, Sarah. Really, really tragic case and circumstance. My comment and question really linked to some of the things that you've said and that Kevin said earlier about handovers and handoffs and about joining dots with partnerships. And one of the words I think you used was about curiosity. So my question is, which I'm not sure we can answer today, is how do we assure ourselves that our people are curious in a way that supports learning from these events and ensures they don't happen again, in a, you know, that we can do as much as we can to prevent them?
Can I just add to that, Sarah, before you answer?
Sure.
Forgive me. And my observation is that this isn't the first report that I've seen and others will have seen that criticises lack of professional curiosity, not just in LPFT context, but, you know, across safeguarding and other areas. So there probably isn't a magic answer. And like Andy, I'm not asking for an answer today, but I think it would be useful if at some point in the future you were able to offer back to the board some reflections around, you know, what's our strategy to make sure, what's our approach to making sure that our staff are appropriately professionally curious.
Yeah, thank you. And Sharon has put in the chat there around it. We do have training around professional curiosity, but training is only part of the equation, isn't it? It's whether it actually does happen.
Absolutely.
And comes to fruition in the care. It's certainly something that was peppered throughout the whole of the Longley's report. So definitely a theme there. Thank you.
Thanks, Sarah. Di.
Thanks, Sarah. Agree. Obviously, a very set of tragic circumstances and a difficult report to read, I found. In terms of, there's particularly one recommendation that stands out for me, which is recommendation 14, which talks about multidisciplinary approach to risk assessment, amongst other things. And I think, you know, as Sharon's already mentioned, there was a definite cumulative risk occurring in this particular family set of circumstances. So I just wondered, in terms of whether there's any appetite in the system, or where we are as a system, of thinking beyond those thresholds or eligibility criteria that are set individually by the contributing agencies, as opposed to for some families like this, where those needs are cross-cutting and complex, a system set of eligibility criteria and thresholds that help us to move beyond, I think, where we've seemed to be for a very long time. And I just wondered about your thoughts on that, really.
Thank you, Di. I mean, that is absolutely an appetite for that, and that's part of you know, the integrated place-based teams work that we're going forward. I see Chris has got a comment, so I don't know whether he wanted to come in on that point.
Yeah, that's right. Yeah, Chris Higgins, Director of Operations. Just, yeah, absolutely. It's the work of the, from a mental health perspective, in work of the integrated place-based teams is identifying what alternative support can be put in place to wrap around people and families such as this, and also connecting in with the other agencies outside of mental health as part of that, and wrapping services around primary care is that's, you know, that's the real agenda that's about. There is no doubt a big cultural shift to do across all organisations, including our own, that for the last decade or more we've been very tightly managed on specified contracts of these are your inclusion and exclusion criteria, and we've drummed that into staff, and now we're saying you need to move away from that, and certainly we're reviewing all our standard operational protocols in the services at the moment and moving away from exclusion criteria to inclusion criteria as part of that, and saying it might not be this particular service, but which service is it, and if somebody doesn't fit any of the services, then how do we work together to make sure it's the best fit with what we've got. And I think that is a different way of working. Just to add to that, I've got a meeting on Monday with all the operational team coordinators and all our operational managers to really reinforce that message around we need to get away from this. It's not us, it must be somebody else, to how can we help, how can we work together, and to offer with the resources we got the best solution for each individual. But I would emphasise that's a big cultural shift from where we've been, both organisationally and system.
Thanks.
Thanks, Chris. I think for me, the point about training is absolutely right, but the bit that underpins all of this, professional curiosity included, is the culture of the organisation, and, you know, the quality of leadership, and that's much harder to kind of pin down. But that for me is, you know, you can train people to be professionally curious, but unless they're supervised, led, directed in a way that values that particular set of behaviours and encourages it, then it's just a bit of training that doesn't stick. Sarah, thank you for stepping up and speaking to that report. As you say, it's not an easy read, and it is a tragic set of circumstances, and there's a lot of, notwithstanding the fact, you know, of the passage of time, there is stuff in there that from which we need to learn and which we need to stay focused on. So thank you for that.
Thank you.
There isn't a there's not an easy way to follow an item like that, whatever, given you know, the fact that it's a difficult conversation around some really, you know, a tragic incident. So you know, there's a bit of a jar whatever we now move on to, but the next item on the agenda is 5.1, and the last meeting of the People Committee. Tim, which is yours. Sorry that you have to follow that other item.
No, I appreciate that. So Tim Harry, non-executive director and chair of the People Committee. So what you have in front of you for this meeting is the full set of draft minutes from the September People Committee meeting. At the last board meeting, you had the highlights report, which very briefly highlighted the need to improve some data to allow better decision making, etc., particularly around recruitment and retention. We talked about ambition in various priority areas, a number of those being in the equality, diversity, inclusion. We talked about recruitment and retention, and Jane is presenting a paper on that, reflecting its criticality. We talked about staff wellbeing service and review of that. We also looked at the staff survey, the cultural barometer that happened, and also the new pathways for children and adolescents, mental health services, and older adults home treatment teams. So hopefully the detailed minutes reflect what we talked about last time in the highlights report, but obviously if there are any further questions, then I'm sure between myself and Jane we can manage.
Thanks, Tim. Any questions or comments from colleagues? Not sure that I see any. Thanks, Tim. I'm great.
Sorry, Kevin?
Sorry, there's some whispering going on, and it's a bit distracting. So apologies.
It's all right. I think Jane's got a comment actually, but I'll come back if necessary.
Okay, Jane.
I just wanted to say there are some comments in the notes when we evaluated the meeting that it was a really positive, constructive meeting, and comments about Tim's chairing as it was his first meeting. So I just wanted to record my thanks to Tim for his leadership in that subcommittee of the board, but also to say that there is positive progress with some significant risks that we're still handling, and the recruitment and retention paper reflects the level of risk associated with that one, which is why we've pulled that out separately. Thank you, Chair.
Yeah, no, thank you very much, Jane. And sorry, I missed your C in the chat. Tim, have you got anything else to add, as long as it's not comments on your chairing ability?
Well, no. I'm fully embarrassed now, but I have to say it was all due to the support that I got from Jane and colleagues, actually.
It always is.
Yeah. I think just one thing to maybe highlight, because I had a bit of a conversation with Andy, and I think it's worthwhile just highlighting. In the cultural barometer, we did highlight the number of positive responses, but obviously the other side of the coin is there was a fairly significant wodge of individuals who neither agreed or disagreed, and then obviously some who did disagree either strongly or not. I think it's important just to contextualise this is part of a broader annual engagement cycle for the organisation, and we was definitely not ignoring those either neutral or disagreement levels, and part of the analysis that will be done. And remember, this was the first barometer survey that was done, so we haven't got the baselining and we haven't got trending yet. But obviously we're not going to be complacent, even if it shows that, you know, we're pretty good in the positive aspects, but, you know, we all always want to improve and hopefully convert some of the disagree and neutrals into agree. So I think it's something we will continue to report on.
Yeah, welcome that very much. Thank you, Tim. OK, let's move on. You've helpfully, Jane, presaged the or prefaced the next paper, which is the Recruitment and Retention report. So I'll hand over to you. Thank you.
Thank you, Chair. Jane Marshall, Director of Strategy and People, and linking with what Tim Harry said from the last People Committee about improving data to allow us to develop an evidence-based recruitment and retention strategy or plan, we've brought this paper forward to give assurance to the board that there is a programme of work in place, not only to focus on recruitment and retention gaps, as my colleague Anita Lewin described when she spoke about safe staffing and international recruitment and other initiatives, but also to focus on the development of a recruitment pipeline and vacancy position predictive analysis to inform our workforce planning and our recruitment and retention planning. I'll take the paper as read, but I just wanted to present this paper to the board to give assurance that the work is progressing. We have quite a lot of work to do to make sure that our data are absolutely 100% accurate from our electronic staff record, but that work is underway, progressing well, and we will be providing further updates to the Board of Directors on a monthly basis, the People Committee in December. And I signal as well, Chair, in this paper, a detailed report on our vacancy, recruitment, retention and risk position to the board development session in December, service by service. That was something you asked me for when you first started with the Trust. So happy to take any questions and to commend Amy Beaton, the Deputy Director of People, who has brought a tremendous skill set to the organisation in focusing our attention on this important piece of work. Thank you, Chair.
Thank you, Jane. I don't see any questions or comments from colleagues. I'm going, at the risk of repeating what you've already said, Jane, this was my one of the first things we discussed when I joined the Trust 6 months ago. It remains for me one of our top 3 operational risks, and I'm really glad to see the progress that's been made in terms of understanding, the metrics around all of this. I think my only comment is let's keep the pace up, please, because I think that given how important, how significant this risk is, I'd like us to see. I'd like us to be able to see this crystallise into something which shows what the current pipeline is in some detail, the risks around that, the operational and financial risks that are wrapped up in it in a way that really hits home and enables us to have our discussions and decisions guided in the right way. We're not quite there yet, but we've made significant progress. So I think my plea is let's keep the pace up and make sure that we can bring this together as quickly as we possibly can. Thank you. Any other questions or comments for Jane? Jane, is there anything you want to add? Sorry.
Just to say thank you for that challenge. I think it's absolutely right. We need to keep the momentum going, and we are doing so. We've done a run for October. We'll be repeating that in November so that we get the data but accurately to our board and People Committee in December. But I think you're absolutely right with the comments that you make, and our staff need us to have that detailed information to know what to be able to do to either recruit new people but also retain the amazing people we've got. So thank you for that comment, Chair.
Yeah, thanks, Jane. And I completely get the point that we've got to build that bit of machinery, as it were, on solid data that we know that we can trust. Getting that right is absolutely critically important. Good, thank you, Jane. Let's move on then to the IPR. Mark.
Thank you very much, Chair. So good morning, everyone. I'm Mark Platts. I'm the Acting Director of Finance and Information for the Trust. So I'm going to present to you November's Integrated Performance Report. We will be basing it on August final data. So we're tracking the late summer data from this one. So As usual format, I'll start going through the national oversight and trust metrics and then hand over to Chris and Jane before coming back myself to look at the sustainability and finance sections. So I'm going to start with a bit of good news, to be honest. So ever since I've been in this role, I've updated the board on the physical healthcare checks and the compliance around those. So we've had some real challenges during the last 12 months, particularly impacted by COVID and staff having to isolate and stuff like that. I'm really pleased to say today that metrics 10 to 12 are now fully compliant. So the team doing a great job and great work by everyone involved in that for pulling that around. So that's a positive. In terms of a couple of other areas, I mentioned this one last month, the improving access to psychological therapies and the recovery rate. That deep dive that the service managers are undertaking to understand the slight underperformance on that one is still ongoing, but obviously as recovery is vitally important, you can see by the compliance of the waiting list targets on there that actually the service are working really hard to keep that service up and running. So as soon as we've got the findings from that deep dive, I'm sure we'll see an improved performance, and I believe we're looking at a December compliance for that one as well. So I'll keep the board updated. Likewise, some positive movement around the consultant-led referral to treatment waits under 18 weeks. So performance is tracking in an upward trajectory. So we are improving month by month, and we are looking to be fully on track by December for that compliance as well. So quite a positive month in terms of the national oversight metrics this month. So if I can, I'll hand over to Chris if there's no questions on the national side of things. Thank you very much.
Thanks, Mark.
Okay, thank you very much. Thanks, Mark. So I just say, I think to give you just a broad overview from the divisional perspective, is that whether it's rehabilitation transformation and stuff we've heard about in terms of expanding community services and reducing the number of people in out of area beds, community mental health transformation, and that's really reaching a tipping point now in terms of some of those early sites are getting to a critical mass where we're going to start to realise the full potential of what that transformation can offer over the coming kind of weeks and months. Things like the digital MAMS pathway, a really innovative piece of work to digitalise that pathway so that the memory assessments can be done remotely and accessed more broadly. And then things that you'll see in the report around the children and young people services being recognised in national awards for the work they've been doing. There's clearly some outstanding work going across all 4 divisions, despite the operating environment we find ourselves in, which continues to be quite a significant challenge. That said, in terms of the challenges, there's a kind of 2 really broad areas where we're finding the most difficulty, and that is recruitment and retention. Particularly to recruit staff at the pace of transformation, an ambition that we've got for transformation across the organisation and the system around mental health. And we've seen lots of investment, but with that comes the need to attract staff in to be able to fill those posts and realise the ambition that we've got. Related to that, but secondary, is the staffing availability on the inpatient wards. As we've introduced new and attractive posts in the community, that inevitably has an impact on staff from inpatient services, seeing other opportunities, and that for a time certainly depleted our inpatient staffing establishments. That triggered a piece of work over the last 6 months, which you've heard about in terms of rapid recruitment, and that seems to have had a really positive impact, where not only have we brought new roles in, it's been new opportunities, more senior kind of clinical roles to be able to oversee and support, as well as recognising staff on the wards to offer different career opportunities, and that has certainly had a significant and positive impact. There's still more to be done, but we're in a much more stable position than we were, say, 6 months ago. So more to do on that, but that's improving. The second bit, beyond recruitment and retention, is demand on services, and that, you know, we're not alone in this as an organisation. Is we've seen demand increase for mental health services and learning disability services across a number of different areas. Some services have got the ability to cope with that more easily than others. Where we're feeling it most keenly still remains on our autism pathway for autism assessment. There's still a gap there in terms of meeting demand, and we've got a significant waiting list. We've just agreed with commissioners, actually this last couple of weeks, that we'll work with an alternative company outside the organisation to try to make some inroads into that waiting list, at least stop it escalating further as we get plans in place for more recurrent and sustainable ways of working. The second piece is around children and young people services, which we know in certain areas we're really struggling to meet the demand, both because of restrictions in practice around having to work and meet COVID related practices, so not being able to work in groups as we've done before, which thankfully we're able to get those back online, and it will increase productivity, but also just the volume of people that's come through. And board members will be aware that we've got a deep dive that's been now completed that sets out what were the challenges and also identifies a number of actions that we think are needed to bring that back on track. And that report is going to the Sustainability Committee next week, so we can have a bit more further challenge and confirm around that. So I'll stop there, and I'm happy to take any questions.
Thanks, Chris. Don't see any questions. Yep, no, sorry, Andy got there just in time.
Just in time. Thanks, Chairman. Andy Spring. Chris is aware of this. Really pleased to hear that Sustainability is going to do a detailed look at children and young people. Just wondered if you could confirm what the if you like the average weight is for children and young people, and what the maximum weight is, because obviously waiting for anyone is a concern, but for younger people is probably particularly important. Just to make sure that assure us that we're doing everything we can.
Yeah, absolutely, Andy. So average weight for our core canvas services is about 7.3 weeks, which against a target of 6 weeks is where we should be seeing people. The longest weight on there is about just shy of 16 weeks, so further out than we would obviously want that to be. But what's important, and some of the work that we're bringing through Sustainability Committee, is that distribution graph that shows the variation and how many people are waiting for how long at the different stages, and so that'll give us that level of information that will help us to drive where we need to target our resources better. But yes, it's 7.3 weeks average, and 15.9 is the longest wait at the moment.
Thank you, Chris.
And Chris, before I move on to other colleagues, there's a related issue, isn't there? It's not just about how long people are waiting, it's what happens to them while they wait. And there's the distinction between wait for assessment and then wait between assessment and treatment. I know all of that is going to be covered in the work that goes to sustainability, but it's just worth flagging that there isn't a single metric that properly captures the experience of waiting from the service user or carer's perspective, and that's what I'm keen that we get closer towards. Not a single metric, but a basket of measures that enables us to appreciate the nature of the wait, as well as just the raw timing.
Absolutely, I can come back on that one.
Yeah, no, please do.
Yeah, just to say that the absolutely. So what we've chosen to do as a service in collaboration with our commissioners is to prioritise that initial waiting time, to try to make sure that somebody who's referred in is assessed so we can understand their needs. But that does mean, because of capacity, we're not able to then start the NICE recommended treatments. So once you start, you need to continue, and there's a kind of secondary wait. So there's a piece of work needs to be done around enough capacity to see people for that initial assessment, enough capacity to see people and start treatment in a timely way, but also when anybody is waiting, and actually throughout their kind of treatment journey, have we got the right measures and support mechanisms in place that people can access support outside and beyond LPFT whilst they're waiting. And just a bit of assurance for board members is that people in that interim wait aren't just left. They do have regular telephone contacts, and to make sure that where they are, they're monitoring the risk of that individual to escalate if needed. But it's certainly far from ideal in terms of where we want to be.
Thanks, Chris. Di.
Thanks, Chris. Di Bailey, Non-Exec Director. I was interested to hear, and pleased to hear, your comments about the autism service, in particular, while we're employing looking to an outside agency to support with the waiting list, thinking about that in the wider context of more sustainable solutions going forward. for me, this was brought to life. Jane and I did a visit to one of the teams last week, and I think the staff there had some really valuable contributions and insights to offer in terms of those, those immediate and more sustainable solutions. So I guess it was just to flag that, and in the light of the story that we heard from Kenneth earlier in the meeting, just to really emphasise, I think, the value of listening to colleagues and including those contributions in how we arrive at solutions going forward.
Yeah, absolutely, and you may have picked up from the report that they've done a series of listening events with the staff from Children and Young People Services. Is really vital to understand their perception of what's going off, what do they think might help, and how we can use their ideas, really, because they know what's happening now to make the difference. And certainly they'll continue as part of our engagement as we continue with this piece of work. So yeah, absolutely, Di.
Thanks, Di. Tim.
Hi, thanks. Tim Harry, Non-Executive Director. I mean, this is such a rich report, isn't it, with so much information in there. I kind of ask myself the question, overall, how well is the organisation doing? I just wonder, and it may or may not be helpful, and probably not for a discussion here, but some other time, is whether a summary of the metrics would go with the narrative that we have anyway in the executive analysis. And by that, I may mean, what are the number of metrics that are actually out of the expected range, and then trends with time. It's a gross oversimplification, I understand that, but it just may be another way of just looking at the data.
Thanks, Tim. I think that's a helpful suggestion. Mark, have you got?
Yeah, thanks, Kevin. So it's great idea, Tim, to be honest. And I think we are meeting with Chris and the BI team and the Associate Directors of Operations next week to build on our board development session and really start to look at some of the examples. And Chris touched on the new approach to kind of looking at the waiting lists and bits and bobs like that. So I'm really keen that we build the BI team to equip themselves to be able to provide all these different movements in kind of activity and data presentation. So yeah, great feedback. Thanks. We'll take that to that session, but we will be seeing a different presented IPR in the coming months to give us more meaningful data, hopefully. Thank you.
And thank you, Mark, and I'm well aware of that, and I will repeat my kind of mantra that I've used with you before, and that is, let's focus on getting insights rather than quantity of data. And going back to my point about CAMS weighting, those insights need to be patient, service user, carer focused insights, in the sense that I think we understand our service better if we understand how it feels to people that are benefiting from it. Sorry, that's in danger of also being my second trite point of the day. I mean, it kind of goes without saying, but it's really hard, I think, and challenging to present data in a way that enables us to try and see our services through that lens. Chris, thank you. I've lost track of where we are on the IPR now, Mark. Who's next?
Okay, no worries, Kevin. So we're going to go over to Jane to talk us through the people section.
It happens every time. I lose track of where we are on it. Go on, Jane.
Thank you, Chair. Thank you, Mark. Jane Marshall, Director of Strategy and People. So throughout the report on the divisional updates, but also on page 23, we have trust-wide people metrics. We're paying attention to line 3 there, the staff turnover rate, where we've seen a steady increase over time in our the number of staff leaving the organisation. So we've done a little bit of a analysis at the executive team to share where the hotspots are, and there'll be more work coming through the recruitment and retention papers that we've discussed previously in the board today as that level of work progresses. I think, as Mark has indicated, there's always been a range target on that particular indicator of 10 to 13%. I'm not sure that works for us, so we'll be introducing a little bit more sophisticated analysis and executive comment on what that means and where our hotspots are in future reports. The section on page 23 around vacancy rates, I think we've rehearsed in various other papers today, but those percentage vacancy rates are shown there by staff group, and you'll see quite significant gaps in vacancies, people recruited in several areas of the trust, including senior medical staff, nursing, qualified nursing staff, and also scientific and technical staff, which again links to the pipeline work that we were speaking about earlier on in the board meeting. My third point is on page 24, where at the top of that page we have trust level sickness absence on an SP statistical process control chart. We're seeing an increase in sickness, which is for obviously understandable reasons to some extent, but just to give the board assurance that we are managing and supporting our staff in line with trust policy to bring them back to work as soon as they are fit to do so. The bottom of page 24 adds some detail for colleagues about our progress with recruitment, particularly of qualified nursing staff, but also some reference there to medical staff as well through the Lincolnshire Refugee Dots project. And a theme for that part of the report is again our reliance on our business intelligence colleagues, who are producing a lot of this data for us and allowing the execs and other colleagues to be able to analyse that. We are always conscious of the value they add, but there is sometimes an issue about capacity that we're paying attention to in terms of number of people in that team, and working really closely with my colleague Mark Platts on that. We've highlighted the quarterly staff survey and the cultural barometer, and just to give assurance to the board that we are tracking very closely our response rate, and those teams where the response rate on the annual NHS Staff Survey needs some focus, and to ask my colleagues who are on non-executive director and executive director visits to remind people to fill in the annual NHS Staff Survey. Thank you, Chair.
Thanks, Jane. Any questions or comments for Jane? No, we've had a good, as it were, run around the issues on recruitment and retention, and we know where that's going to come. As usual, you know, this is helpful. We need, as without the risk of repeating myself, we need to locate that in that kind of wider picture of what the future risks look like, but that's helpful. Thank you. Mark, back to you.
Thanks, Kevin. If I can just pick up on just something James just sort of said there, and it's been a very definite theme throughout today's meeting again. So one of the immediate focuses I've got over the next coming months is to really support Rebecca Allen, our Associate Director of Contracting and Business Intelligence, to work with the BI team and try and improve kind of our processes and get resources into the vacant posts that we've got, because the pace of change and the data and the information and, as you say, the insight we require on that change, it is rapid, and I think the team needs to be agile enough to adjust to that. So that's a key priority of mine as we're coming up. So if I can just close the presentation of the integrated performance report by looking at the sustainability factors. So from a finance position that starts on page 21, the board and those public watching will notice that from our financial performance viewpoint, we're almost a sea of zeros. So for the first half of the year, we have broken even. So we have met our targets that we've kind of been given as a system. And quite pleasingly enough, actually, as a system, we've also managed to hit our control total targets that we were given. So quite a positive start to the year. However, I'm acutely aware that a lot of that is driven by the difficulties that we're having to recruit. So I'm really hoping it's kind of a non-recurrent benefit, because it's important we get staff in post and we can work on sustainable services. So in terms of that, we are, as a finance community, we are still collating our plans for the second half of the financial year. I am very aware that we're already a month into that. So nationally, plans are due to be submitted in just over a fortnight's time. So hopefully, once those have gone in, we'll be reporting against the balanced position as a system, and I will be bringing through private board later a paper detailing the risks and mitigations that we have against some of the challenges for the next 6 months from a financial viewpoint. So for year to date, we have met our targets. For the forecast for the remainder of the year, it's going to be a challenging 6 months, as nationally we start to recover from the impacts of delivering COVID support during the last 12-18 months. In terms of agency staff, Anita mentioned earlier on that we are trying to look at different ways of utilising agency staff. So the block booking has definitely helped with rates. And just to echo Jane's feedback on Amy Beaton, the Deputy Director of People, she's brought some really great innovative ideas around working with agencies. So myself and Amy have met with our agency provider, and we're looking at piloting a new way of working with them, which will increase our ability of looking and working with more agencies. So that should help not only bring additional resources in, but actually start to manage costs as well as we widen that pool of supply, which is quite a positive step forward. I can't not mention our capital position. So in terms of our capital investment, we are reporting a year-to-date underachievement on our plans. So we are only achieving just shy of 60% of our plans. We do continue to report 100% compliance. That's upon instruction. So we have now been working with NHS England and Improvement, our regulators, to allow us to adjust that forecast moving forward for the rest of the year. So I suspect from month 7 onwards next month, we will see a reduced forecast trajectory on that one. So there's a lot of pressure in the final 6 months of the year to bring capital expenditure back online. However, saying that, work on our eradication of dormitory schemes on the Lincoln County site is really progressing well. So we've now got concrete on the piles that we have on the ground, and steel frames are almost complete. So it's really looking like a positive build now, and that scheme is well on track for delivering and opening awards in 2022. So there is positive developments within our capital position as well. So I'll pause there and happy to take any questions on the sustainability report or any other element of the report. Thank you.
Thanks very much, Mark. Any questions on the finance element? Tim.
Hi. Thanks for that on the finance question, really around the sort of capital. So the major part of the capital expenditure is around the eradication of the dormitories, and I assume that's ring fence money, so it can only be applied for that. I just wondered then, with the likely forecast to change in the second half, which I can understand, for a variety of reasons, are there any implications in terms of annualised capital budgets, i.e., have we got at least an informal agreement, or what? How are we going to handle that, I guess, is my question.
Yeah, it's a great question, Tim, and it's something that I'm working closely with NHS England Improvement reps on. So we now meet with them weekly now to try and keep the pace on this. So with that ring fence money does come a delegated limit that we can spend up to, and any underspend on that does present challenges in terms of carrying it over year on year. So I mean, to be honest, a bit of context, this is a national issue. I mean, even regionally, I suspect we're over 60-70 million pounds underspent year to date. So I think it's something that needs to be looked at on a national level from a capital expenditure limit viewpoint. So we're certainly pushing that through region and working with them. That they are being supportive as much as we can, and I think that there's something about focusing on the end of the scheme delivery, because we do have expenditure limits throughout the next 2 or 3 years as the schemes progress, that we can kind of team and label and move across the different schemes. So we do have a degree of flexibility, but there is an element of risk there, but it is a national one, not just a local one, so I suspect something will need to be done, because whilst these schemes are significant for Lincolnshire, there are much bigger schemes across the country being delivered. So
yeah, no, thanks for that.
Thanks, Mark, and that answers the question I was going to ask, so I'm grateful. Any other questions or comments on the IPR? If there aren't, I'm going to, if people will indulge me, take a 5-minute break, because I'm really struggling with tech at my end at the moment, and it might have shown, but I've got a dreadful lag for some reason on my network, and some of the conversation I'm finding really hard to follow. So I'm going to suggest that we have a 5-minute break so that I can log off and log back on again, and see if that makes any difference. So it's now 20 to 12. If we reconvene at 1:45, please. Thank you.
Thank you.
Kevin, can I just speak so you can check if the time lag has sorted itself out?
That's much better.
Okay, thank you.
I might actually be able to follow what's going on now.
Always helpful for the chair.
I'll repeat myself because I hadn't realised I wasn't off of mute, so I'll do that bit again. We're all back, so Andy, it's over to you in the Audit Committee. Thanks.
Thanks, Chair. Andy Spring, Chair of Audit Committee, Non-Exec Director. Happy for my colleague Audit Committee members to add to this, but these are the draft minutes of our meeting on the 7th of October, and are provided to the board for information. I'll take them as read, but I'm happy to take any questions or comments that people may have.
Thanks, Andy. Any questions or comments for Andy? I can't see any, and I don't have any. They're quite self-explanatory. Thank you, Andy. And I think the next item is also you, which is the Audit Committee Annual Report.
Okay, thank you, Chair. This is the Audit Committee Annual Report and is brought to the board for assurance that we have met our terms of reference, and for the board to provide this report to the Council of Governors. I really would like to put on record my positive relationship that our organisation enjoys with both internal and external auditors, and how capable our officers and their teams are, both in supporting this committee and in responding to internal and external audit recommendations. And I think it's really important. It makes the work of the audit committee very easy relatively, and without that positive response to our auditors and that support, our job would be much more difficult. This report represents the work of the audit committee over the year 2020-2021, but hopefully is self-explanatory and demonstrates that we've met our terms of reference. Again, happy to take any questions or any comments that anybody has.
Thank you, Andy. It's a self-explanatory report, very helpful, and as you say, it I think provides assurance to the board that the audit committee is meeting the expectations that the board would have of it, and it's and fulfilling its terms of reference. So I'm grateful. Thank you very much.
Thanks, Chair.
Let's move on then to item 7.3, the board assurance framework. Peter.
Yeah, thank you, Chair. I'm Peter Howie. I'm the Trust Secretary. So the board assurance framework is the document the board uses to record all of its overall strategic risks and assurances. Each section of this is maintained by a committee of the board, and the sections are here. The report sets out where there remains partial assurance. There's no area anywhere where we have no assurance. So we have partial assurances around vacancy and recruitment and retention in the people section, which of course have been addressed extensively already within today's meeting. Within the quality report, Sharon's already mentioned earlier in the meeting where we are in terms of looking at outstanding partial assurances there. And within the Sustainability Committee, they meet next week and have a significant number of assurance papers on that agenda, which I believe will probably move some of their partial risks back to, partial assurance back to substantial assurance. So I think the report is as it is. It's already been seen by each committee. It's just for the board to firstly determine if there's any questions or challenges they wish to make, and then if not, to approve it as a safe and accurate record of the level of assurance available.
Thank you, Peter. And the important point about this is that it has had a good going over in each of the committees. So the detail reported here and the level of assurance reported here is the level of assurance recommended, as it were, by each of those committees. Tim.
Hi, a very quick comment and sort of analogous to the integrated performance report, and I just wondered what could make this even better is just a summary of the high level metrics around, you know, numbers that we've got with full assurance, la-di-da-di-da, maybe a simple table.
Yeah, we put a table in the covering report and just a table of for each committee how many are in each assurance. Yeah, we can do that. We'll avoid using colours in it though, because some people have colour issues, so we'll use words instead.
That sounds like a really good idea. Thank you, Tim. Thanks, Peter. Jane.
Sorry, Chair, thank you. Jane Marshall, Director of Strategy and People. There is a recommendation around a transfer of the just culture risk in Peter's paper. I'd like to just comment on that, if I may, Chair. It's in the executive analysis.
Yeah, got it. No, please do. Yep.
I don't disagree with the transfer. I just think just culture and the attainment of a just culture applies to all of us and all of the subcommittees of the board, therefore. And there is something I think for us to think about, maybe about how we reference our work around just culture across all of the different board committees, but also the board of directors and the wider organisation itself. So it's just a comment rather than a fully formed version of anything particular, but I'd welcome the opportunity for us to discuss that at some point if that's appropriate. Thank you.
That sounds sensible, and it would need to be pitched in a way for those of us that don't know what a just culture is to understand exactly what we were proposing to transfer and why we were proposing to do it. So maybe that is perhaps not a discussion for right now, but it sounds like a discussion that needs to be had at some point. Sharon.
Yes, thank you, Chair. I'm in agreement with Jane. That specific risk, though, which is risk Q2.1 under our strategic priority 2, relates to the HR policies to determine appropriate application of the just culture. So it's specific to people and the HR policies.
Okay. I don't feel adequately equipped or prepared to have a conversation about that right now. It sounds to me like something that either needs to be resolved offline and then brought back to the board if there really is a substantive issue that the board needs to decide on. Any other questions or comments? I don't see any. Thank you very much, Peter. I think with the addition of the kind of summary table that Tim has suggested, that would make that report even more useful. Thank you. I think the next item, Peter, is also yours, which is the review of governors' responsibilities and code of conduct. I know this has kept your midnight oil burning for some time now.
Yes, it has, Chair. Okay, so we every 2 years review both the governors and the directors' responsibilities and code of conduct. This was reviewed back in April. Subsequently, further comments were received in relation to further clarity and 1 or 2 cross-referencing, and importantly, the use of digital technology with the opening of NHS Net to governors to use requires certain safeguards to be in place around that digital technology, which should therefore be written into this code.
I'm not sure whether I've still got you, Peter. You've frozen. And I don't know whether you've frozen just for me or for other people.
He's gone for me as well, Kevin.
Yeah, and for me.
Okay. Good. It's not just me then. Thanks, Karen. There's nothing else that we can really move on to while Peter restores himself, because we're about to come to the end of this morning's proceedings. A meeting that has unfortunately been slightly plagued by technical issues.
Back in now. Come off and come on again.
Yeah, I think we've just lost a stack of it going through trust headquarters.
Okay.
Okay, we are still live, and I've just put you back on live, Kevin, but it looks like we may have lost the people that were watching as well. It may have been a Teams issue that went down completely.
Okay.
But it looks like we are still going.
Yeah. We don't appear to have any attendees, so.
And just let me check we've got enough people in the meeting to actually for the board to be quorate. Yeah, we have. Yeah.
Okay. Carry on then, Peter. Let's bring things to a slightly shambolic conclusion.
Yeah, I'm not 100% certain where you heard me up to, but essentially changes at governor's requests and the additional safeguards around NHS Net have both been built into this. And the governors had an opportunity to look at it. They agreed it at their meeting. However, this is for the board to approve, not for the council of governors to approve. So it is here for approval.
Excellent. Thank you, Peter. Has anybody got any questions or comments? I can see Philip is typing furiously, so I shall wait and see whether or not that's a question or a comment before I move on.
Thank you, Chair. I was just typing yes, getting ready to approve, actually.
Excellent, well done. So the question is whether the board approves these changes. If anybody thinks otherwise, please shout. That's great. Thank you very much. And I think then, apart from the forward board programme, Peter? We're nearly there.
Yes, we are. The forward board programme, all the dates as usual. Just to flag for people's attention, on page 2, there are 2 changes to the programme. To the forward agenda that was approved at the last meeting. One relates to the employee relations report because the update is now an integral part of the IPR and work being done by the People Committee. So there's not going to be a separate interim report on that this year, but we'll be back to the annual report in May. And the second just relates to, I'm afraid there's an error, we missed a couple of lines off, we've put them back in, and there's the record of having done so.
Excellent, thank you, Peter. Comment, Philip.
Yes, thank you, Chair. Just Philip Jackson, Non-Executive Director, Chair of the Sustainability Committee. Just to mention that the timing of the next Sustainability Committee has been moved forward from 9:30 to 9 o'clock because of the size of the agenda. So I think that just needs to be noted as well.
Thank you, Philip. And sorry, I should have pointed this out. So has the joint board been moved forward by half an hour to start at 9:30?
Thanks, Philip. Thank you, Peter. Has anybody got any other business? I've not been notified of any. No one's putting their hand up. That just leaves, I think, the review of the meeting, and I don't want to prolong this because we've obviously got some gremlins in the IT system somewhere, but I'd welcome any immediate comments or feedback on this meeting. It's been a tricky one for me because technology's not been on my side, but if there are any other comments or feedback, be glad to get them. Sarah.
Thank you, Kevin. I've really enjoyed it despite the gremlins. I have to say, I like how we kicked off with the staff story there rather than patient story, because I think the theme a lot from the day was around sort of recruitment and retention issues. So I felt like we had a golden thread there. So thank you.
No, thank you, and you know. I feel more comfortable saying it now that Ken isn't here, as it were. I thought that Ken's story is genuinely an inspiring one, and I don't want us to just one observation, and that is, you know, there's now a long queue of people wanting him to do things. Let's please not overburden him and you know, give him the impression that he's become you know, kind of a symbol of whatever, but we just want to, let's just be measured in the way in which we draw on that experience and that story, and don't, I would hate for us to give him the impression that we're holding him up as some sort of paragon of virtue and feel under pressure as a result of that. Yeah, so let's just be conscious of that. Thank you very much. That's been really helpful. Now we meet in private, and my suggestion is that we do so immediately, that we go straight into our private meeting, and that we deal with that with a degree of pace so that we finish in good time for people to grab a sandwich and whatever else they want to do for lunch. So if people are happy to draw this meeting to a conclusion and then jump straight back on for our private meeting, that would be great.
Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you. Thank you.